Indications. We wrapped it all up into the simple mechanical things that if you've only done 10 or less, you can certainly tackle when you leave here today and certainly after tomorrow. Loose bodies, labral tears, FAI, we'll learn more and more about it as the days go on. Snapping psoas, osteonecrosis. Some people are talking about treating osteonecrosis, and some of these things are a little bit far out there. Synovial disease, mild degenerative disease, chondral injuries, ruptured ligamentum teres, impinging osteophytes, kind of early arthritis again. Instability is being bantered about in the literature. Subtle subluxations, capsular-related instability from aggressive prior surgery. Adhesive capsulitis of the hip. Joint sepsis, that's a stretch, but we do it in kids. Unresolved hip pain for diagnostic arthroscopy, and then trochanteric bursitis. So what are the contraindications? I found on the web this morning, I didn't even know I was looking at it first because it was a thumbnail. But even in the thumbnail setting, I was like, so I use a mini C-arm. So my clinical assistant and I have just, we have our own C sign. It's like this or like this. And if a patient's walking down the hall, and I'm like, we need to sign Mrs. So-and-so up for surgery. And Sarita will go, and I'll go, oh yeah, order the big C-arm, because I do a mini C-arm in an outpatient setting for everybody, obviously not this patient. Local soft tissue disorders, open wounds, poor bone quality. These are generally contraindications to a lot of joint surgeries that we do elsewhere in the body. Severe obesity may be a relative contraindication just because of your logistics and your setup, and you really have to think about it. You may have to augment the table. If you have some of the tables that are more balanced or don't have the great balance mechanisms that the new Arthrix table may have, you have to think about what's the reality of the limitations of your setup. Literature says, labral repair definitely. There's great literature out there, more and more every year. Labral repair and FAI in pro hockey players. Here's one of Philippon's papers showing a relative significantly increased Harris hip score from 70 to 95 in a 2-year period. Again, Larson's study, HHS score in the 70s rose to 88.9, good to excellent results in 2/3 with the debridement group versus almost 90% with refixation. So I can't remember the last time I went in telling the patient my goal was to debride their repair. I don't know what that is, sorry. Labral repair again in Philippon's study, all healing due to microvascular scar tissue, all repaired labra were stable. This is in a sheep model, so even in the animal models it seems to be holding true both in the clinical setting and in the lab. Just like in knee surgery, we repair cartilage though, there's remaining this shallow cleft at the junction between the labrum and the articular cartilage, and that makes sense. Just like anywhere else in the joint, especially the knee, we can never get cartilage to heal side to side, so we're coapting it, getting a fibrovascular seal with scar tissue at that chondrolabral junction. And we'll talk a lot about different techniques when we do the demos and are in the lab about trying to maintain an intact chondrolabral junction if possible. Labral reconstruction, 32 patients and 15 women, 32 men and 15 women, average age which you'd expect. Just short-term follow-up, HHI score rose from 62 to 85. 4 patients went on to a total hip arthroplasty, so obviously just like in the meniscal transplant world in the knee, we're going to overstretch the bounds in the early pickups in the literature. This again is a Philippon paper looking at labral reconstruction. A lot of people using different tissues, mostly allograft and some autograft, I should say. Rolled up IT band or a little gracilis. Labral repair with chondral lesions. So this steps up the grade of the problem a little higher. With no cartilage lesions, all patients were improved. With significant chondral lesions in this study by Strike, patients showed no improvement or deteriorated. So we still haven't conquered the early chondral damage along with the labral tear. The low-hanging fruit, isolated labral tear. The higher hanging fruit with a bruise below it, the chondral lesion. So we haven't conquered that certainly yet. Long-term follow-up though in labral repair in this study by Bird. At 10 years, all patients with associated arthritis and labral tears went on to a THA. So that speaks against it. But that's again patient selection too, and this is out of 10 years, just to throw a curveball at us. Labral debridement, outcome of resection of labral tears. Here's just a study that said Strike again back in 2007, minimum 2-year follow-up, modified HSS, went from 63 to 85, and the LHS from 57 to 79, and this is with a limited follow-up. And most of us know, if we follow our patients far enough, that if we just debride the labral tears, when they are repairable, the patients seem to do worse. I think we'd all tend to agree. Osteoplasty with osteoarthritis, or arthroscopic treatment of FAI with perioperative or preoperative generalized degenerative changes. Sounds bad. 10 had gone on to a total hip at 3-year follow-up. The remaining 10 had improvement in pain and improvement in motion. So depends on what the functional goals are, but this is, tread carefully in this area where you already have defined objective criteria for arthritis, and we haven't conquered that, but we're working on it. Osteoplasty, 200 patients in this large bird study with limited follow-up, 12 to 24 months only. The average increase in the HHS score is, again, significantly, at least clinically, 20 points. And then FAI in 45 professional athletes, kind of the top end of the spectrum of who we may treat. Limited follow-up again, 93% return to sport, but we don't know how long that held out for. 78% remained in professional sports, though, at an average of 1.6 years. So that's promising, and it makes us sound like clinically and functionally we're heading in the right direction. The trochanteric bursitis, the role of arthroscopic bursectomy in the treatment of trochanteric bursitis. How many of the faculty, I'll just ask us, have done isolated trochanteric bursectomies? More than maybe one a year? Not many, right? So, yeah. And I don't know, and this is interesting. I mean, sometimes we do them in conjunction with other things, but it's almost like in the knee, it's akin to an isolated lateral release. Probably not indicated, probably most of the time. IT band release, endoscopic treatment of the snapping hip, iliotibial band and iliopsoas tendon. Both are effective procedures for pain relief in the literature, and this is Zolaturi out of Sports Medicine Arthroscopy back in 2010. Occasionally, continued painless snapping persists despite an adequate release. And then the snapping hip, again out of Lesior's clinic, endoscopic release for external snapping hip. Looked at just 11 patients, a small cohort, average 2-year follow-up. All but one patient had complete relief. The remaining patients were symptom-free. Release or fractional lengthening at the joint. You can see the shiny, what's showing up there? The psoas going across the bow here. Here's the labral hemorrhage here. We talked about that juxtaposed labral tear below the psoas. Pain score decreased from 7.7 to 2.4 significantly in the HHS score. Went from 56 to 88 with the Harris hip score, sorry. Ligamentum Teres, arthroscopic surgery for degenerative rupture. One patient, 2-year follow-up, this I found late last night, completely symptom-free. In the Journal of Obscure Findings. It's the Apomoto on arthroscopy, but you never know. Gluteus Medius, there's more and more reports. This is one I pulled on the airplane coming up. It was in someone else's talk, actually. Endoscopic repair of gluteus medius tendon tears of the hip. Hip outcomes score of 93. So, this is something that I think we miss a lot, and we're starting to be better at picking up at it. And even I have family practice docs in our area sending them to me, fully diagnosed, fully worked up, and I'm amazed. I'm like, wow, it's pretty impressive. So we are learning. This is what the medius and the greater trochanteric looks like. We'll see this in a demonstration, but Kelly had a report where 7 of 10 stated their hip was normal, and 3 out of 10 in a small group of 10 were nearly normal at almost 2 years of follow-up. And then Dr. Dohm's own paper on partial thickness tears. I think, is this going to be part of a demo later? But he showed us a great technique of how to see that hidden lesion. It's like the hidden lesion akin to the hidden anterior horn flap tear in the meniscus in the knee. It sneaks up on the patient, sneaks up on us. Unless you know to look for it or imaged it astutely with a good MSK radiologist, with or without gadolinium, I guess, you're going to miss it unless you're thinking about it clinically, because it's not staring us in the face. It's below a normal external portion of what apparently normal appearing tendon. And I'll let Dr. Dohm tell us more about that. So that's just a brief kind of end of the loop here, just a quick overview of almost everything we're going to touch on or have touched on. And are we heading to the lab? No, not yet. Not yet. Oh, and that's the end of A section.